On November 9, 2018, I saw Mr. VC in the surgery heart failure clinic complaining of shortness of breath, dyspnea, and chest pain. He's a 38-year-old Caucasian male with a past medical history of hypertrophic cardiomyopathy, diabetes, and hypertension, and he was referred from his cardiologist, Dr. Brown, for surgical evaluation. The patient explains that he experiences shortness of breath, night sweats, dyspnea, fatigue, and lightheadedness on a daily basis at rest. These symptoms are exacerbated whenever he goes to bed at night, lays down, and exerts himself. He also claims these symptoms have become progressively worse over the last 6 months. Sitting in a chair, he reports his pain as 5 out of 10, but claims that when he exerts himself, it can become as high as an 8. The patient was diagnosed with the hypertrophic cardiomyopathy and diabetes 2 years ago. He went to the ER with a sharp chest pain, and there he was diagnosed. Since then, he's been evaluated by his cardiologist, Dr. Brown, and he has reported noncompliance due to failure to obtain insurance, but he does have insurance at this time. The patient had an alcohol ablation 1 year ago, but unfortunately it was not successful in treating his symptoms. Other surgical history includes an appendectomy in 1999 and a rotator cuff repair in 2014. The patient's family history is significant for his father dying at 35 from an AMI, and his mother is currently living with dementia. The patient lives with his wife, mother, and child. He is on full disability, and he denies alcohol and drug use. He does admit to smoking cigarettes. He smokes about 7 cigarettes a day and has a total history of 11 pack years of smoking. He denies hemoptysis, palpitations, headache, and cough, and he denies a history of stroke and heart attack. The patient does report an allergy to tramadol. He had facial swelling, and his medications are metoprolol and Trulicity for diabetes. The patient's vitals were stable. He had hypertension, so 130/92. He's a little hypertensive. His blood pressure, his pulse was 108, so he was a little tachycardic, and respiratory rate was within normal limits. The only physical exam finding was a systolic murmur on the left sternal border, which I heard on his chest. He had regular rate and rhythm otherwise, and no accessory muscle use, no adventitious breath sounds, good musculature. The patient does have is a little overweight. His BMI is about 31.9. The cardiologist did prior workup, so I evaluated labs, CMP, CBC, PTI, and RPTT. Wanted to make sure that if we needed to do anything emergently, he wouldn't be bleeding out on the table. Wanted to make sure those labs, PTI and R, were within normal limits. The only thing elevated was his glucose and his A1C. Diagnostic study workup, EKG had shown LVH, dilated left atria, abnormal T-wave elevation. Cardiac MRI had showed similar things, also asymmetrical severe hypertrophy of the basal to apical septum and basal to mid-inferior wall, consistent with hypertrophic cardiomyopathy. It showed normal RV systolic function, normal LV systolic function, a Charter's scar in the basal septum at both anterior and inferior right ventricular insertion sites, common in the pattern with hypertrophic cardiomyopathy. The systolic anterior motion of the mitral valve leaflets were also dynamic with a left ventricular outflow tract obstruction, and there was moderate mitral regurg, which was consistent with what the systolic murmur I heard on physical exam. Echo was also similar findings, severe concentric left ventricular hypertrophy. Ejection fractions on both the right and left ventricles were greater than 70%, and mild mitral regurg was also shown. I diagnosed the patient with obstructive hypertrophic cardiomyopathy. Due to the patient's symptomatic condition and his previous alcohol ablation failure, I knew that he would be a candidate, found him to be a candidate for a septal myectomy. I had planned to discuss and evaluate the imaging with cardiologists and surgeons to discuss the exact plan for the resection of the septum. And I was going to discuss the risks of the surgery, which included infection, bleeding, removing too much tissue from the septum, causing a ventral septal defect, and also arrhythmias such as complete heart block. I would also plan to order additional diagnostic studies, which include PFTs, chest x-ray, for standard surgical clearance. The patient also has diabetes with hyperglycemia. I'd encourage him to get his blood sugar under control because increased blood sugar causes reduced healing times. His hypertension continue with his medication. The patient is overweight, so I want him to eat well-balanced meals so we do not increase his weight. Follow-up, I would go ahead and plan a time for surgery after making a plan with the cardiologist. Follow up on those PFTs, chest x-ray, ultrasounds, get pulmonary for clearance if there were any issues, and post the surgery to the OR. Thank you so much. That's my patient.